Hi, everybody. Neal Shore, Start Cancer Research. Um, it's a great pleasure for me to speak with you today. Um, I really want to talk to you about changes that we are pending potentially for our patients with high risk non-muscle invasive bladder cancer, specifically the results of the POTOMAC trial. And this is adding a checkpoint inhibitor, Durvalumab, to traditional induction and maintenance BCG intravesical regimen. So one of the questions I oftentimes get is it feasible for urologists to administer and manage durvalumab themselves? I think it absolutely is, but like with anything new that has a different mechanism of action, and we've seen this throughout GU oncology, one needs to become knowledgeable and familiar not only with the mechanism of action, but also safety, tolerability, adverse event management, uh, education for patients and their families before beginning therapy, and what to expect afterwards. Having a multidisciplinary team with a nearby medical oncologist is also another option that works very well. In terms of barriers to the adoption, to adding durvalumab to BCG regimen, it's really just educational. Um, that's the key thing, learning about what is involved. So we see this with other therapies along the continuum of geo-oncology. In our prostate cancer patients, we had to learn about androgen receptor pathway inhibitors, also called ARPs, and we've learned about other forms of therapy in prostate cancer, radiopharmaceuticals, immunotherapies, PARP inhibitors, and in bladder cancer, very importantly, perioperative issues and regimens inclusive not only of traditional chemotherapy, but also checkpoint inhibitors. Durvalumab is approved as a perioperative regimen. We have other immuno-oncologic agents and antibody drug conjugates now in the perioperative space and in advanced bladder cancer as well. So, what barriers do I perceive from a patient perspective to add durvalumab to the BCG regimen, particularly in high risk non muscle invasive bladder cancer patients? I think this is important that the notion for patients to appreciate that there are additive increases in side effects, but there's a benefit to be gained. So one has to understand a person's risk tolerance versus their risk aversion to get the clinical benefit. And what is the clinical benefit for the high risk non muscle invasive bladder cancer patients? Well, we're trying to prevent them from getting not only recurrences, which require more resections and biopsies and anesthesia and potential complications of that, but also, more importantly, progression to the point of disease getting more invasive within the bladder wall and ultimately leading to the consideration for bladder removal, which we oftentimes call cystectomy. Um, and finally, do the improved cancer specific outcomes make the trade-off of adding an infusion of a checkpoint inhibitor such as durvalumab to the BCG regimen worthwhile? I would categorically say 100%. Um, and this goes to the important notion now that we require our colleagues, our healthcare providers, to do shared decision making with the patient. We are clearly moving away from a sort of a paternalistic view that we're the doctor, we're going to tell you what you're going to do. Patients have to have choice. And it's not always completely clear, but having really good, full throated discussion and letting patients and their families understand risk benefit analysis of added benefit with the trade off that there can be some side effects. So I hope this was helpful. I think AUA this year, like last year, a tremendous amount of exciting data on in GU oncology. Thanks very much for listening.